to the session of the 2025 Culture of Data Conference. Thank you so much for joining us. My name is Peggy Jarrett, she, her, hers, and I'll be moderating this session. We also have Ann Hill, she, her, hers, who is managing the Zoom and making sure that all the tech is running smoothly. You're all muted now, but if you have any question during the Q&A sessions at the end of the session, just feel free to unmute yourself. You can also use the chat box if you have questions or need anything, and we'll try to keep monitoring that. If you're comfortable doing so, please add your pronouns to your Zoom name by clicking the 3 dots on your video square and selecting rename. We have one presentation during this session. They will present for approximately 25 minutes, and then there'll be about 10 minutes for Q&A afterwards. And so what they are talking about is Family Connects, a universal approach to addressing social determinants of health for postpartum families. And I can say that I work at Good Samaritan, and we are about to start on our Family Connects progress here at my hospital. So I'm going to turn this over to Kelly Steinbach, Tracy, Kate Follett, and Delaney Murray to give their presentation. And I think Kelly is going to start out with it.
Yes, thanks so much, Peggy. And Delaney's going to pull up our slide presentation to share. And while she's doing that, we can also introduce ourselves. As Peggy said, my name's Kelly Steinbach Tracy. I work at the Public Health Institute at Denver Health. And I use she, her pronouns, and really excited to be here to talk to you today about the implementation of Family Connects in Denver and Jefferson County and the exciting data that we're gathering to inform our community services. And I will pass it over to Kate to introduce herself next.
Good afternoon. My name is Kate Follett. I am a nurse supervisor with the Jefferson County Public Health Department, and I use she, her pronouns. And I will pass off to Delaney.
Hi, everyone. My name is Delaney Murray. I use she, her pronouns as well. And I'm housed at the Public Health Institute here at Denver Health. I support the implementation of the Denver County Family Connects program as a community alignment specialist. And I also support our Jefferson County Family Connects program with their data. So great to be here. Thanks for having us.
And you could go to the next slide, Delaney. So first, we wanted to touch on why did we choose Family Connects to implement? And one of the first things that we know, or one of the reasons that we chose it, is that we know that bringing home a newborn, although it's a very exciting time for families, it can also be very overwhelming, and many families have additional stressors in addition to bringing the newborn home. And so Baby and You data, which is data collected via survey by the Colorado Department of Public Health and Environment, shows that among families with newborns, 13% of them are experiencing financial stress. 29% are experiencing parental symptoms of anxiety, and 38% of them say they want or need mental health services. However, of that 38% who say they want or need that type of service, 37% indicate that they are not able to access the services that they need. And so we know there's a high need among families, and so we're going to talk to you about how Family Connects helps us improve these important outcomes. The other thing to note about data in Colorado is that child maltreatment is most prevalent in the early years, with nearly 1 in 5 children who are impacted by child maltreatment being 1 year or younger. And so we know that this is a very vulnerable time for families. And so by having programs that help support families, strengthen families, and reduce stress, that we can help families with some of these things and improve their outcomes. Next slide. So in addition to the data indicating the need for a program like Family Connects, Family Connects was actually researched using randomized control trials. It was researched in Durham, North Carolina, in partnership with Duke University. And when public health and child welfare partners came together, they examined this evidence and found it to be really compelling. So among mothers who participate in the program, we saw the research indicated that they were more likely to complete their 6-week postpartum health visit. They were also 28% less likely to report postpartum anxiety. For the babies, they had 50% lower rates of emergency department and overnight hospital stays in the first year of life, and that was sustained through the 5th year of life, which is pretty exciting. We also saw some significant findings for families, including more positive parenting behaviors and home environments, 15% more community connections among families who participated, and also a 44% reduction in investigations of child maltreatment. And those findings were sustained through the child's 2nd birthday. Further, the Family Connects research shows that the program actually decreases disparities, so decreases the gap between racial groups for both the findings for maternal anxiety and child welfare referrals. Next slide. So one of the things that's really unique about Family Connects is that we're serving families while we're improving systems. So this is a public health program that is designed to provide a service to families, and it has an intentional community alignment and data monitoring component built into the program. And so in addition to providing this direct service for families, we're also able to see how well is the network of support working for families. What are challenges or barriers that the families we're serving are findings, and what are the gaps in services? And so we use this program data to improve the system of supports, and that actually ends up helping all the families in our community, whether or not they participate in the program. Next slide. So I'm going to turn it over to Kate, who's going to tell you more about the Family Connects program model.
Thank you, Kelly. Okay, so let's start with a really broad view of the model. Family Connects is really centered around one home visit per family. That one home visit is typically about 2 hours long. The goal is that the nurse goes into the home, builds a little bit of relationship with the family, and then together the family and nurse co-identify what needs they might have. Depending upon the needs, the nurse might be able to meet those needs directly in the context of the home visit. This happens most commonly if families just have a lot of questions and perhaps they just need some information and validation. However, typically what is identified is that the family needs some ongoing needs that cannot be met within the context of the home visit, and therefore the nurse facilitates a connection to a community resource or perhaps a healthcare provider or whatever it is that that family needs to get their needs met. And the goal of all of this, as Kelly referenced, is to build a parent or caregiver's bandwidth to really connect with and bond with their baby. A couple key points of the model that I want to talk about too before I dive a little bit deeper into this one home visit. The target timeframe for this one visit is about 3 weeks postpartum, and that is by design, that is intentional. We are trying to break up that very long 6-week window between discharge and the woman's postpartum checkup or the birthing parent's postpartum checkup. We also know in this country that a lot of negative outcomes can occur for moms and babies in that window. So we're trying to intervene and prevent that. Another key part of this model is that the program is universal. So there are no income restrictions, there are no risk factor criteria. And this is really important when we're talking about improving systems, as Kelly mentioned. It's also important to note that this service is offered at no cost to families. If we charged, that would influence the universal nature of it. So, Delaney, if you don't mind going to the next slide, let's dive a little bit deeper into this one home visit. We call it the IHV, or integrated home visit. The nurse is trained to assess the family's current level of functioning across 12 factors, 4 domains, and we call it all the family support matrix. So you can essentially think of it as an assessment matrix. So the 4 domains are support for healthcare, support for infant care, support for a safe home, support for parents. Within those 4 domains are the 12 factors you can see. The nurse assesses those 12 factors using a variety of validated screening tools, nursing assessments, discussion, etc. And then based on those variety of assessments, the nurse rates the family in each factor from 1 to 4. A score of 1 essentially means the family they're rocking it. They got what they need, they're doing great. A score of 2 is kind of that nurse education piece I mentioned, where like the nurse is able to meet the family's needs within the context of the home visit. A score of 3 or 4 indicates that some sort of external connection is facilitated by the nurse. So before I kind of scope back out a little bit, I do just want to briefly mention that this model does allow for up to 2 follow-up visits as needed and as determined by the nurse and the family. Okay, so next slide, please, Delaney. I want to scope us out a bit, and we're going to talk about the 3 core components of the model. So the first core component is the home visit, and that is indicated by the stethoscope at the top. So without the nurse home visit, the rest of this wouldn't have much value. So that is one core component. The next core component is community alignment, which I'm going to talk just a little bit more about. And the last core component is data, which Delaney is going to chat more with us about. So to dive a little bit deeper into the community alignment piece first, there are several domains that we talk about when we are referring to community alignment within Family Connects. So I don't want to spend too much time here. I'll go around kind of quickly. I'm going to start with the agency finder, which is essentially a resource directory. Simplest way to understand it. It's a resource directory that lives within our electronic health record. And the point of that is to help facilitate the nurses' ability to quickly look for local resources for family needs. The next component or domain of community alignment is engagement. By this, we are essentially talking about family voice. Within the Family Connects world, we typically refer to these folks as family ambassadors, and we value them greatly within this program. The next domain is case conferencing. This is a pretty typical process for nurse home visiting programs. Part of the purpose is, supporting nurses in this work. It can be kind of hard, morally injurious sometimes to do this sort of work. And so part of it is supporting nurses. However, I think the difference with Family Connects is there's a really intentional focus on how do we take what we learn in case conferences and take it back to inform the community. The next domain of community alignment is the post-visit connection, or we call it the PVC. This is a connection point that is made about 30 days after the home visit. It is typically initiated by a program support specialist. So in other words, not the nurse who did the visit. The PVC is typically done via phone call, but can be by email or other methods. And the point of the PVC is twofold. One, assessing the family's satisfaction. Did they feel respected by their nurse? Did they receive the support they were hoping for? Would they recommend it to a friend? The other point of the PVC is assessing the success of those connections that the nurse facilitated. So of all the referrals or resources that the nurse provided, how well was the family able to engage in each of those resources? The last 2 domains, I'm not going to spend much time on because that's Delaney's sweet spot. So the last 2 domains are data and community advisory board. And I will let her talk more in a moment about how we utilize the data from this program to inform the CAB and therefore community systems change. Before I hand off to Delaney, though, I'm going to kind of go sideways a little bit and talk about how this program is being implemented here in the state of Colorado. So we have a national purveyor, Family Connects International. Kelly referenced them. They developed the model, researched it. They are essentially responsible for making sure that we're all implementing the model to fidelity. Here in the state of Colorado, we are somewhat unique in that we have a state intermediary and an administrative home. I personally feel lucky to have that support, and we have Illuminate Colorado to thank for offering that backbone support for us here in Colorado. And then as this point, the program has been fully implemented in 4 counties: Eagle, Boulder, Jefferson, and Denver. It is already growing though, so there are already other counties getting on board. Hopefully yours will be on board soon too. Delaney, do you mind going to the next slide? Here's some slightly deeper information, details about how the program is being implemented in these 4 counties. As I mentioned, the model is meant to be universal. Our goal is universalism really across the country, where no matter where you're born, you get a Family Connects visit. And in order to get there, we gotta reach certification and show that we can successfully implement this model here. And therefore, we are implementing it a little bit differently in different counties. So this slide kind of looks over that. But to dive deeper into the data, I'm going to hand over to Delaney, and she is going to share a little bit more about the data we have been gathering from Denver and Jefferson.
Great, thanks, Kate. Yeah, so today we're looking specifically at Denver County and Jefferson County. As Kate said, there are 2 other counties who have implemented here in Colorado. Jefferson County implemented their program a little under 2 years ago, and Denver a little under 1 year. So as she said, we're still kind of getting the plane off the ground and getting the program to full capacity. And so when we talk about what we call population reach, we think about how many families have received a Family Connects visit out of the eligible birthing population, or EBP, of our area. So that last slide showed the EBP for Denver and Jefferson County. And here is a breakdown of the race and ethnicity of the patients who have received a Family Connects visit in both counties. So as you can see, we see some differences in each county, which will be a recurring theme as we show data from both Denver and Jefferson County. So right now, we're seeing the vast majority of the patients in Denver County identify as Hispanic and Latino. The second is Black and African American, and then just a little over 5% that identify as white. Whereas in Jefferson County, the patients who have received a visit, about a 50-50 split between those who identify as white and Hispanic and Latino, and then a little under 5% that identify as Asian. And so something I want to name is that as we're ramping up the program and working towards full capacity, per the Family Connects model, the aim is to serve 60% of our eligible birth population. So as Kate said several times, this is a universal program. The aim is to offer it to everybody that lives within that EBP. And the hope is that 60% of them do end up receiving the visit. And so we're not quite there yet. Denver County each month is seeing between 15 and 20% of their EBP right now. And Jefferson County seeing right around 10 or 11% of their EBP. And so we both have a long way to go. But I want to name that something we very much intend to do as we get closer to that 60% population reach is to really compare our demographic data to that of our eligible birthing population. So we receive that data every month from the state and want to really make sure, for example, in Denver County, if we're seeing that 18% of our eligible birthing population identifies as Black and African American, but we're seeing less than 10%, how do we address that gap? So are we not reaching those patients? Are they not consenting as frequently? And how can we kind of take some quality improvement steps to make sure that our numbers are really reflective of the population and that we truly feel like we are serving the community that exists in our counties? And so just want to name that something that we certainly intend to do, but haven't yet because we're not really seeing enough of the population that we feel it would be extremely accurate right now. And then this is kind of a breakdown of the caregiver insurance status, again, for the patients who have received a Family Connects visit in both counties. So again, we're seeing a little bit difference in the breakdown of insurance status between Denver and Jefferson County. And I think that this makes sense when we think about both our eligible birthing populations in each county and also how we're recruiting patients. And so in Denver County right now, we are recruiting patients directly from the birthing hospital floor at Denver Health. And so it makes sense that a vast majority of our patients are publicly insured or uninsured because that's also the vast majority of the patients that are seen at Denver Health. In Jefferson County, kind of in contrast, we do send Denver Health patients that are Jefferson County residents over to their Family Connects program. And they also do quite a bit of their recruitment at pediatric and women's care provider clinics. And so it also makes sense that people who are getting their prenatal care or their pediatric care at those clinics are also privately insured. And so their demographics are just a little bit different. And I think that really speaks to the universal nature of the program, that all of those patients are being seen by this program, but are also benefiting from it. So this next slide shows the identified areas of support needs by county. And so, as Kate said, every family kind of gets assessed in these 12 domains of the family support matrix. And then this is looking at any family who identified a 2 or higher in any of these areas. And so again, a 2 means that they probably just got some type of education while the nurse was in the home. Maybe they got directed to a specific resource or a handout or other information that supported that need. And then of course, a 3 or 4 means that they were connected to a community-based resource. So it's unsurprising, as it should be, that we're seeing like kind of some different support needs for each county based on the socioeconomic situation of those families. So Denver County, for example, a lot of our families are identifying need for support in terms of materials, which could be food, clothing, housing, baby items, formula, things like that. Also a significant amount that are addressing like healthcare plans, caregiver well-being, and then specifically childcare. Whereas on the other hand, we see that the Jefferson County nurses are really supporting families much more frequently with caregiver emotional support, caregiver well-being, and parent-child relationship. But I definitely want to name that these categories of support are not mutually exclusive, right? They're very interdependent on each other. And so we think of it kind of in terms of the Maslow's hierarchy of needs, right? If a parent is facing food insecurity and they're not really sure how they're going to feed themselves or their baby over the next month, that need is going to take priority for them over maybe, you know, the bonding that they're experiencing with their baby, right? But that we also know that by getting them connected to those food supports, we're gonna, you know, we're benefiting the caregiver well-being, right? And that getting a family connected to a resource that's going to supply a stroller or a pack and play, we know that that's going to support the parent-child relationship as well, right? So just naming that these are really interdependent and that supporting a family in one will almost always support them in another area, or at least increase their capacity to kind of work through that on their own. And so it makes a lot of sense that we're seeing sort of a difference in the needs of support for families, and then we can address those specifically. So that's one benefit of the universal program, is that we can be really intentional in the way that we connect families to sort of the safety net supports that exist in our community, or to kind of higher level supports that they might need. And so I think one thing people might think is like, you know, if we are seeing so many families in our community and the goal is to connect them to community resources, like what does that mean for those community resources, right? Are they going to get overloaded because people are being sent their way that might not otherwise? But I think this speaks to the intentionality behind, like, instead, we will make sure that people that really need these services are getting connected to them, and that those who could benefit from something else are also getting that type of support. And so we can see that a little bit in the specific community referrals that each county is making. And I won't spend too much time here, but for Denver County specifically, again, it's unsurprising that the majority of the referrals that are being made are for places like WeCycle, Marisol Family, places that offer clothes, baby items, diapers, formula, things like that for families. That close behind that is SNAP or food stamps. And then of course, childcare services like Head Start, Early Head Start, or the Colorado Child Care Assistance Program. And so we can really see how these referrals fall into those various categories of support needs, right? And then very similarly, we'll show Jefferson County, and we can see that a lot of their families had support needs in caregiver well-being and emotional support. And so it makes sense that a lot of their referrals are to mental health providers or to support groups. And again, you know, the nurses are always kind of doing that triaging and making sure families get the right fit for them. So if a family would benefit more from like a peer-to-peer group where they're just getting to talk to other birthing people and create that community, then that's where they're sending them. And if a family really needs that individualized therapy or more intensive support, then that's where they're going to go as well. And so seeing that a lot of their referrals go to providers, whether maternity care, pediatric, or primary care, Again, it just speaks to the fact that we're sending families where they really need to go, right? This isn't just a talk to every family and give them a referral, but really being intentional and good stewards of the resources that we have in the Denver metro area. And so what do we do with all this information besides share it with you? This is where our community advisory boards come in. So a really key component of the Family Connects model is engaging a community advisory board. So every county that implements the program also has this group of stakeholders and engaged community members who are also serving children and families in their communities. And so this is results from a survey that we did in Denver County with our community advisory board, where we really wanted to understand, what information are they hoping to glean from Family Connects that can also help inform their own programming and can help us do some of that systems level change. And so we have a lot of community advisory members that serve specific demographics in the Denver metro area. And so they really want to know, for example, we have resource centers that are specifically focused on reducing maternal mortality rates for Black mothers. And so they really only want to see this information for our Black and African American birthing people. And so that's something we can kind of drill down and get specific for them. But we're seeing that pretty much across the board, all of our community advisory members want to see those areas of need. They want to see the community referrals that are made. We have a few members who are more involved with the provider aspect of perinatal health care and want to improve those systems and that experience for patients. And then people want to see, like, what are our gaps in service, right? What are the things that families need in Denver or Jefferson County that we're really not able to meet with just a referral to a community-based agency? And so this is just kind of the things that they've told us they want and some ways that we've done it. And so some of the examples of how we're using this data for systems alignment, I know Kelly touched on this a little bit at the beginning, but as we engage that CAB, we really are trying to identify those gaps in resources, as I said, and then any barriers to service. And we have a couple cool examples from both Denver and Jefferson County of ways that we've been able to do this since our programs have launched. So in Denver County, for example, our nurses were frequently referring families to WIC to get them to address their food insecurity. But what they were hearing time and again from patients was, oh, I called the number, but no one answered. And I've called 3 or 4 times and no one ever answers, can't get a hold of anyone. Or, yeah, I've had WIC benefits in the past, and then I had to reschedule my my renewal visit. And then it was 8 weeks out and I completely lost my benefits in that time. And I have this newborn and I'm going 8 weeks without my WIC benefits. And so just constantly hearing how families were getting disconnected from services or weren't able to connect in the first place. And so we took that information, we reached out to our WIC program manager here at Denver Health, and we set up a meeting, and we learned a lot of information from that meeting. So we learned a lot about kind of the shortage of staff that they were experiencing, the decreased capacity, and how that was really leading to the things that our patients were seeing. So we learned, number one, that it's true, no one monitors the WIC phone number. You have to leave a message and someone will call you back, but no one is ever going to answer that number. And so unless we're encouraging patients to leave a message, they're not going to get contacted that way. Another thing we learned was that it was true. They're 8 weeks booked out on visits. And if somebody cancels their renewal visit, according to their grant requirements, they can't continue their benefits. They have to pause them until that renewal visit. And so really stressing the importance of keeping that visit as often as possible or as much as possible. And then we also learned about their partnership with the Jefferson County WIC program to kind of address this staff capacity. And so Jefferson County WIC was actually taking Denver patients and was able to see them and get them signed up for benefits in a more timely manner. That's not something that we knew about. That's not something that was, advertised on the WIC website or really well known. But because we sort of sat down and had that intentional moment of like, how do we improve this system for families? We learned this. And so now, our nurses encourage patients, if you're going to call, you have to leave a message with your name and number for them to call you back. If you have an appointment, please do not cancel it if at all possible. It's really hard to get rescheduled. And then also, if you're willing to travel to Jefferson County, you can get this appointment in a week instead of 8 to 9 weeks out. And so it just really has improved that system for families. And we're seeing now families are connecting to WIC. Another example out of Jefferson County Family Connects program, they were referring families to the Action Center to support them in applying for benefits. And what they were hearing from families was that they weren't really getting connected. So they're calling this phone tree. It's very confusing. They're not sure what to press or where to go to get to what they need, right? I think we've all been on a phone system like that and felt frustrated. And then when you add on the layer that families are also trying to receive benefits to meet their basic needs, that's a huge barrier for families, right? And so they actually brought that information back to the Action Center and shared it with them. And because of that, the Action Center kind of redesigned their phone tree, made it more accessible for families. And now when they refer them there, their families are really getting connected. So just the ways that we really want to improve the referral coordination. We're not just giving families a phone number to call, but we want to follow up with that PVC and say, did you get connected? Are you receiving this? And if not, how can we support? And then another piece that, as Kate said, we really value with Family Connects is engaging our family leaders and the voice of people in our community that we want to serve. And so in addition to our community advisory board, we have a family advisory board made up of parents and caregivers of young children. And they help us with a multitude of things, but specifically around data, they can support us in making sure that we have culturally relevant resources so that every family we're serving is getting a resource that feels like it feels good for them and is accessible and in the language of their choice and is reflective of their own identity. And so they're really helpful in that regard, and then reaching underrepresented populations. And so we really have so many wonderful family ambassadors that are kind of on the ground floor as just wonderful advocates for our program, and they're sharing it within their communities, with their neighbors, their families, their friends, and are really just a testament to the fact that the program is meant to be family-centered. So I will go ahead and pass it over to Kelly to talk about some of the lessons that we've learned so far with this program implementation. Kelly, looks like you're on mute.
And I had launched right in too. So yes, there's a lot that we're learning when you're implementing a public health program that provides direct service. So one that has come up is these competing demands. So an example is we have a charting system. So we're providing a nursing visit, right? And so we have to chart in a way, and we're planning to bill Medicaid and hopefully someday private insurance for sustainability of the program. So we have to chart in a way that's appropriate for medical settings. So the chart is really set up to be more like an EMR or medical record and less like a data collection tool. And we are also using the same charting mechanisms to collect data. And sometimes there's just challenges like where the data goes and how we pull it out, and making sure that when drop-down menus are utilized, and making sure that nurses know that they need to utilize those drop-down menus instead of free text whenever they're presented, because we can't mine the free text for the data that we might need, for example, related to referrals. And so that's one of the things that we've had, that we've talked about across sites, and just really streamlining and making consistent the way data is charted, so that the community alignment specialists across all of the sites can find the data that we're needing. There's also some challenges with program level longitudinal data. So Delaney showed you data on demographics. She showed you data on percentages of needs, and she showed you data on percentages of referrals and that sort of thing. And we certainly can. We have the capacity to, or we have the technology, I guess, to follow that, so that we could know, among the Hispanic patients that we're serving, what are their needs and what referrals are they getting, so that we have it across longitudinally. But it's more challenging, and it takes more data capacity, and it would take downloading the data and exporting it into a better system for analyzing data. And so those are things that we hope to do in the future, but that we haven't gotten to yet. We're mostly pulling the data and utilizing the data functions that exist in this charting system. It's a Salesforce database, and some of those things are a little bit limited for some of the data data that we'd like to do over time. And I do think we'll build our capacity to do that, but it's something that we've recognized as a challenge. one of the things that we've learned is that direct service approaches are critical for serving families and for gathering data. For maternal child health, we're really lucky here to have the Baby and You survey that Colorado Department of Public Health and Environment puts out. And we get the data from that survey on a yearly basis, and they are very timely, but to have a year's worth of data, you have to wait for all the babies to be born in that year. And so it takes some time to actually understand what a birth cohort of 2024, what the data looked like for them. And we're lucky because some states only have prams. For one thing, I don't think prams is even up anymore. But when it was often more like 2 years out. So you were getting data about a 2024 birth cohort, sometime in 2026. And so that was challenging as well. So the Family Connects program actually allows us to understand the families in our community in real time. And that is incredibly exciting and helps us meet those population needs while we're also meeting the individual needs of families. The other challenge with this program, or with any program, I think, that provides a direct service component, is that sometimes that community alignment, like when funds are tight and you want to keep the program, that part might not always be seen as critical as the direct service component. And so it's one of those things we can't bill for that community alignment component. But what we recognize is that the changes that we're able to make in the systems that benefit all families, whether or not they participate in Family Connects, are as critical as the services that we're providing to the individual families that we get to see. And so when I think about, is this a public health program that's direct service, or is it like environmental policy and systems change? I really think it's both. And that is one of the reasons that we were really drawn to implementing Family Connects. Next slide. All right, so in summary, we've told you that Family Connects is a direct service program with the goal of improving population, maternal and child health, and the data that we gather is critical to achieving that goal. We are happy to stop for questions about the presentation that we have provided, and if you don't have questions for us, we have some for you. Feel free to come off mute. We're happy to hear your question out loud.
Or you can put it in the chat, either one. We're watching the chat, but you can very easily unmute yourself.
Hi.
Claire?
Yeah, thank you for that presentation. That was lovely. I am coming from the perspective of, I'm the director of health equity for a nonprofit that has a very similar structure of home visiting. So I very much see and value the impact you all do. I'm curious because of my role. So I work at the national level, and curious what your perspective is in terms of the supports that you all, so it's a twofold question. What types of supports do you all currently receive from Family Connects International, and what would be kind of the best optimal type of supports that you would want to receive from, the national or international level of the organization to support your work on the ground?
I can chime in on that, and then I would invite Delaney and Kate to chime in as well. So Family Connects International does provide quite a bit of support. One of the things that they really provide is infrastructure. So the database that I referenced that we chart into is a database that they developed. So they provide that infrastructure to all the sites, which obviously helps them too, because then data is collected across sites, not just in Colorado, but nationally more consistently. They also they provide our nursing clinical training so that nurses are all trained in a similar way as to how to implement the model, and they provide ongoing support for that as well. And then they provide training for other roles in the Family Connects model. So the community alignment specialist role, the program support specialist role, some of those trainings are in the form of like asynchronous videos, but they also have support people. And so I would say they do provide quite a bit in terms of infrastructure, and then also in terms of policy. They've helped connect us with other states who've implemented policies that have supported the implementation of Family Connects. For example, Oregon, Family Connects is required to be covered by private insurance, and we would love to model something like that. And so they connect us across the nation with sites that may be farther ahead or maybe doing some innovative things in the realm of policy or some other clinical systems change or community alignment. So they create learning across sites as well. That's all I can think of off the top. Delaney or Kate, would you add additional things to how Family Connects International supports?
I think just one thing kind of in line with that, I think they create opportunities for like cross sharing and learning for almost every role. So for example, they hold space for all community alignment specialists to come together and talk about, what are your strategies for engaging an effective community advisory board? What are some specific things that you'd like some extra support around and things like that? So I think they really try to make sure that each component of the model feels supported by others across the nation who are implementing.
I don't have much else to add. Delaney kind of commented on what I was going to comment on, which is that Family Connects International also hosts a monthly supervisor space, and the value that I see in that space is shared learning. Yep.
Two other things I thought of. One is they establish what they call the KPIs, the key performance indicators that are the for across all sites in the nation, and that gives us goals. So it's they establish those expectations, but then also support sites to meet those expectations. The second thing is our model is a little bit different in Colorado because we do have a state intermediary. So while the sites do have some connections with Family Connects International, the way we've talked about, Family Connects International primarily supports our state intermediary, who then provides support to us. I think I saw Megan enter the room. Megan, if you want to add anything else. Megan White is at our state intermediary, Illuminate. Not to call you out, Megan, but
I am here and I'm loving it. I'm loving not presenting too. So I would just say that Illuminate Colorado is a state intermediary for this program, and we really try to just provide tailored support as well as advocacy. This is a nationwide program. And I think one of the big roles that we're able to do as a state intermediary is translating things into the Colorado context, as well as providing feedback to the national organization about, customizations we may need, innovations we want to put in place. And we've been able to influence the national discourse that way, in a way that I think if it was just individual sites within Colorado, we wouldn't be able to.
Any other questions?
I'm not seeing anything in the chat.
Right on time. We did great.
So first of all, I'd like to thank everyone. I think we had up to 36 at one point people attending this session. And I want to thank Kelly and Kate and Delaney, of course, for their wonderful presentation. And I want to thank Ann Hill for being the tech support for this session. A few short announcements before you head out. Slides and any additional handouts are available on Sched. I haven't looked to see if they're actually been downloaded yet, but they were supposed to be. So hopefully that is still true. You can see that there's a QR code there for the conference evaluation. You're also going to receive a conference evaluation form via email after the conference is over. So if you can, please fill that out. Even if you've only attended a portion of the conference, it's very helpful to our planning committee. This is the last live session of the conference. If you enjoyed this conference, we encourage you to check out Public Health in the Rockies, which is a great event also put on by the Colorado Public Health Association each year. And that's going to be in September. Check out the website coloradopublichealth.org for more information. The recordings will be live next week, and we'll follow up with an email when those are ready. So once again, thank you for supporting CPHA and for joining us for these sessions the last couple of days. We hope you had a great couple of days connecting with other public health professionals, and have a great weekend. The rain's going to stop, and it's supposed to get nice tomorrow and Sunday. So have a nice weekend.
Thanks, everyone.
Thank you.
We appreciate you coming.